So welcome to the Kanski lecture series, and this is going to be the uveitis part 11, and in this part we are going to discuss about the viral uveitis. First of all, we are going to discuss uveitis in human immunodeficiency virus infection, which is known as HIV. Introduction: human immunodeficiency virus infection or acquired immunodeficiency syndrome AIDS is transmitted by the unprotected sexual intercourse via contaminated bloods or needles and vertically from mother to child transplacentally during birth or breastfeeding. So majorly the serum and the bloods are the route of transmission of HIV infection to the other person, especially through sexual intercourse, through transplacentally, through blood needle pricks during birth or breastfeeding. HIV depletes CD4 positive T cells, which are vital to the initiation of immune response to the pathogen. So, what does HIV do? It basically kills the CD4 cells, which are basically needed to kill the infections. Although there is currently no cure or vaccine, the progression of the disease is slowed radically by the combination drug therapy, antiretroviral therapy (ART). ART is now recommended for all HIV positive individuals, irrespective of CD4 positive T cell count. Prophylaxis against opportunistic infections may also be instituted. So basically, heart, what we known as a heart, is the therapy which is recommended for the AIDS, and basically, and you also treat give antibiotics for the other opportunistic infections. So what are the systemic features? So stages of infection: number A is a flu-like illness, may occur 2 to 4 weeks after infection, sometimes including a rash. Then there is a clinical latency, is predominantly asymptomatic period of several, average 8 years, sometimes with minor clinical features such as persistent generalized lymphadenopathy. AIDS develop in half of the HIV positive individual within 8-10 years and is defined as an HIV infection with either a CD4 T positive T cell count less than 200 cells per microliter or the development of one or more AIDS defining condition. So basically there are three courses. One is where there is a pre-tromal phase in which there is a flu-like illness, then there is a latent period for several years, and then there is an AIDS which occur when the CD or 4 count ratio is less than 200 cells per microliter. So, what are the AIDS defining clinical conditions? Include particular opportunistic infections such as respiratory or esophageal candidiasis, pneumocystis jirovecii pneumonia, cryptosporidiosis, and cytomegalovirus retinitis. Specific tumor including Kaposi sarcoma and certain lymphomas and other manifestations such as HIV wasting syndrome and progressive multifocal leukoencephalopathy. So these are the opportunistic infection that occur in a case of AIDS. Number one is there can be the respiratory or esophageal candidiasis. Then there is a pneumonia which is due to pneumocystis jirovecii. Then there can be the cryptosporidiosis. Then there can be the in the eye there can be the CMV retinitis, and then there can be tumors like Kaposi sarcoma and lymphomas, and there can be HIV wasting syndrome and progressive multifocal leukoencephalopathy. So let's see figure 12.4a is showing examples of the A defining condition. A is showing X-ray showing pneumocystis pneumoniae. B is showing Kaposi sarcoma. C is showing HIV wasting syndrome. D is showing numerous molluscum lesions. Ocular features may include number eyelids is contains of blepharitis, Kaposi sarcoma, multiple molluscum lesions, and herpes zoster ophthalmicus. So basically, the eyelid contains blepharitis, it contains Kaposi sarcoma, molluscum contagiosum, and herpes zoster ophthalmicus. In orbit causes cellulitis, for example, aspergillosis, contagious sinus infection, and B cell lymphoma. In conjunctiva, it also causes uh, certain cancers like Kaposi sarcoma, squamous cell carcinoma, and microvasculopathy. Then comes the cornea. Cornea, it causes the dry eye, keratoconjunctivitis sicca, and increased incidence of keratitis, for example, herpes simplex and zoster and fungal. Anterior uveitis occur with ocular infections or commonly with the drug toxicity, for example, rifabutin and pseudofiber. Very important for the MCQ's point of view. Which medicines causes the anterior uveitis in a case of AIDS? It's the rifabutin and pseudofiber. Then there is an HIV related retinal microangiopathy. Retinal microangiopathy is the most frequent retinopathy in AIDS, with AIDS developing in up to 70% of the patient. It is associated with declining CD4 positive T cell count and high plasma HIV RNA level, and is a marker of increased cytomegalovirus retinitis risk. So basically, when there is a decreasing CD4 T cell count, it causes the CMV retinitis. Postulated causes include complex deposition, HIV infection of the retinal vascular endothelium, and abnormalities of the flow. So first most common cause of the HIV in the retinopathy in HIV is the HIV itself, a retinopathy, which is causing the microangiopathy. Second is the CMV retinitis, and the most important causes due to the immune complex deposition. There is a retinal vascular endothelium HIV infection and the abnormalities of the flow. It manifests with the cotton wool spots and or retinal hemorrhage, and sometimes capillary abnormalities such as microaneurysm. In contrast to CMV retinitis, lesions are asymptomatic usually and almost invariable, disappear spontaneously after several weeks. So you can see it is an HIV microangiopathy. Retinal angiopathy, microangiopathy is associated with declining CD4 positive T cell count and is a mark for increased risk of developing cytomegalovirus retinitis. Next is the other viral retinitis, CMV retinitis. Most common progressive retinal necrosis, acute retinal necrosis, protozoal toxoplasma retinochoroiditis, often atypical. Fungal include pneumocystis choroiditis, histoplasma chorioretinitis, cryptococcal choroiditis, and candidiasis. Bacterial include syphilis and tuberculosis. Neoplastic contain the B cell intraocular lymphoma. Neuroophthalmological, usually secondary to meningitis or encephalopathy due to an opportunistic infection, for example, toxoplasmosis, cryptococcus, and neurosyphilis or neoplastic process, for example, CNS lymphoma. So these are all the conditions that causes the that occur in a case of an HIV. Next is a CMV retinitis. So CMV is basically itself a virus, and it is most commonly occur in a patient who are already having an AIDS or having an HIV. In introduction, infection with the CMV cytomegalovirus, a herpes virus, is a very common in general population, causing no or minimal constitutional symptoms in most healthy individuals. CMV retinitis is seen in a patient with immunocompromise from a variety of the causes. It is a common opportunistic ocular infection in a patient with AIDS, who it may represent a reactivation of a latent infection. So very common in a case of immunocompromised AIDS. Without treatment, several visual loss is essentially inevitable. Since the advent of the ART, the incidence and severity have declined, though prevalence remains high partly due to increasing survival rates in AIDS patients in whom systemic steroid therapy may be a risk factor. There is a strong association with the low CD4 positive count. So what are the systemic features? Severe involvement of the range of organ including the lungs, CNS, and skin can occur in immunocompromised. So ocular features. So remember always a pizza pie, like it occur in a quadrant and it give us like a pizza appearance in which there is a whitish lesions and with the reddish hemorrhages, like a pie of the pizza. Presentation is with reduced vision from the macular involvement or with floaters from vitritis. So if the macula is involved, the vision will be reduced, and if there is a vitritis, there are going to be floaters. One eye is usually affected initially, progressing to both eyes in 50% of the patient if untreated. Indolent retinitis frequently starts in periphery without symptoms and progresses over week. So it starts at the periphery. So interior uveitis can occur but is usually mild with little or no injection. It is considered separately later in this chapter. Cataract is a common later stage finding. Vitritis is typically mild except in immune recovery. Retinitis. The characteristic appearance in one or two areas of intense white retinal infiltration associated prominently with the flame-shaped hemorrhage pizza pie or margarita pizza begin peripherally, centrally in 10% and extending along the course of a vascular arcade. So very important, it is occurring along the course of a vascular arcade, and it is having a white, basically the whitish retinal lesions, and between them is a hemorrhage. We can see figure like a early retinitis. You can see that it is a whitish lesion and there is a hemorrhage associated with it. Peripheral areas tends to be appear granular with full rounded hemorrhage and little vasculitis. Indolent, more peripheral and less aggressive and fulminant clinical patterns have been distinguished. The visual acuity can be significantly reduced if the macula is involved. Optic neuritis may result from the direct spread or from primary involvement. So then there can be retinal necrosis. Retinal necrosis is evident in areas where active inflammation has settled, leaving irregular pigmentation, atrophy, and holes, frequently leading to retinal detachment. So retinal necrosis can occur with the case of a CMV, which is basically due to the due to inflammation, which is causing irregular pigmentation, atrophy, and hole formation ultimately leading to the retinal detachment, a major cause of a visual morbidity up to 50%. Next is the frosted branch angiitis. FPA described mark vascular sheathing that occur in about 6%. This appearance is seen in other condition, and the term is also used for the distinct idiopathic disorder, primary FPA. So basically there are two types of FPA: frosted branch angiitis, primary and secondary. The primary is due to idiopathic and secondary is due to the other condition, especially CMV. We will discuss in the later topic, and basically it is causing the sheathing around vessels. So let's see figure 12.51. A is showing early retinitis, B is showing indolent retinitis with typical granular appearance and retinal vasculitis. C is showing advanced disease, showing extensive macular exudation. D is showing posterior retinal tear with a shallow localized detachment. There is vascular sheathing reminiscent of the frosted branch angiitis. So you can see that here is a sheathing of the vessels that is occurring. Next is the immune recovery uveitis, which is known as IRU. Basically, when you give the medicine to patient, so due to the response, it further aggravates the inflammation. This is cause of a limited visual outcome in CMV retinitis, thought to be due to regenerated immune response against the residual viral antigen following immune reconstitution with the ART. So whenever there is going to be the immune reconstitution and the immune reconstitution fights the remaining viral antigens, it causes the aggravated immune response, which is known as immune recovery uveitis. Manifestation can be severe, progressing to phthisis in some cases. So next is the treatment. So what is the treatment? Close liaison with an infectious disease physician is critical. ART. So you are going to give ART if the patient is having an AIDS. ART is the mainstay of arrangement, restoring the patient innate ability to suppress CMV activity. Discontinuation of the antiviral treatment is considered when the CDR4 positive count reaches greater than 100 to 150 cells per microliter. So you have to give them ALT until the reaches the 600 to 100 to 150 cells. Then there is a valve. Ganciclovir is a prodrug of ganciclovir that is taken orally and is effective for both induction 900 mg twice daily for up to 3 weeks and maintenance 900 mg daily. Neutropenia is a common side effect due to bone marrow suppression but can be effectively treated with filgrastim, granulocyte colony stimulating factor. So most important drug in the treatment of the CMV is valganciclovir. Basically it is a prodrug which converted into ganciclovir, and induction dose is basically you give 900 milligram BD for 3 weeks and then you give 900 milligram daily, and its side effect is neutropenia, and which is treated by the filgrastim. Next, another can use ganciclovir, carnet, and cenofiber given intravenously were formerly key therapeutic agents, but substantial side effects have largely led to its regulation to reserve status. Then there is a ganciclovir slow release intravitreal implant. So basically, you can also give intravitreal ganciclovir, which is implant for basically effective for the almost 9 months. Ganciclovir slow release intravitreal implant is now less commonly used, but it still has a utility in situations such as intolerance to systemic treatment. It is as effective as intravenous therapy, and duration of efficacy is 8 months. Intravitreal injection of other agents such as foamipirine and cidofovir may occasionally be indicated. Vitrectomy with endolaser demarcation and silicone oil tamponade is successful in around 75% of the CMA related retinal detachment. So when there is a retinal detachment, there can be due to CME, you can do vitrectomy with endolaser. Then steroids may be required for IRU, though intravitreal and systemic administration should be used with caution. So whenever there is IRU, you can give steroid as well. Prognosis: this is a poor despite treatment if the macula is involved. Screening of the patient with low CDR4 count, 3 monthly, less than 50 per microliter, 6 monthly for 50 to 100, and yearly if greater than 100. So next is this is the implant. A is showing a slow releasing ganciclovir implant used in the treatment of cytomegalovirus retinitis. There is associated localized lens opacity. So there is a lens opacity you can see here. B is showing a regressing retinitis after treatment. So next is the progressive retinal necrosis. Very important topics are PRN, which is known as PORN, and ARN, acute retinal necrosis. So progressive retinal necrosis, PRN, also known as progressive or progressive outer retinal necrosis, PORN, is rare but devastating form of the necrotizing retinitis, which is usually caused by the varicella zoster virus and possibly other herpes virus. So majorly PORN is caused by VZV. It occurs predominantly in a patient with AIDS. So it occurs in immunocompromised, but may be associated with other immunocompromised states, particularly drug-induced. Prognosis is extremely poor. No perception of light. The outcome in with no perception of light, the outcome in more than half of the effector time. So what are the ocular features? Presentation is with rapidly progressive unilateral and bilateral visual loss. Anterior uveitis or vitritis are minimal in contrast to CMV retinitis and acute retinal necrosis. So basically, anterior uveitis and vitritis are minimal. Retinitis, 3 stages are recognized: early, established, or middle, and late. So the early phases containing of the multifocal homogeneous yellow-white deep retinal infiltrate. The macula may be involved at an early stage, often giving a cherry red spot. So early stage, it contains macula is involved, in which causing the cherry red spot, and there is a deep retinal infiltrate, yellow white deep retinal infiltrate. Let's see figure 12.53a is showing macular involvement, and it is giving the cherry red appearance and giving the deep yellow white infiltrates. Next is established or middle. This sign typically spread rapidly around retina with very extensive full thickness necrosis. Signs of vasculitis are absent or mild, and significant hemorrhage is uncommon. As inflammation clear, perivenular translucency is seen. So basically, in this, the necrosis has spread widely, and there is no hemorrhage you can see, there is no vitritis you can see, and there is no signs of vasculitis. Late is showing the rhegmatogenous retinal detachment is common, as is optic atrophy. So the late stage consists of optic atrophy and the RRD. Vitreous investigation, vitreous or aqueous PCR for viral DNA antibody assay is less effective. Treatment, immune rescue with ART together with aggressive antiviral therapy, for example, intravitreal or intravenous ganciclovir and foscarnet. In vitreoretinal surgery for retinal detachment often yield poor result. So basically, you treat it with the as the patient is immunocompromised, you treat it with the ART plus antiviral therapy. You can give intravitreal and intravenous calciclovir and foscarnet. Next is the acute retinal necrosis. ARN is a rare but devastating necrotizing retinitis. It typically affects otherwise healthy individual. So you can see PORN occur in a case of immunocompromised, whereas ARN occur in a healthy individual and tend to be caused by the herpes simplex virus in younger and VZV in older patient. Other herpes virus are also suspected. So HSV occur in younger, where VZV, older patients are much immunocompromised, occur in the older patients. Other herpes viruses are also suspected. The prognosis is relatively poor, with more than half of the patient eventually achieving only 6 by 68 as a result of the retinal and optic nerve ischemia or RRD. So visual prognosis is poor, and more than half of them will achieve only 6 by 60 vision because of the retinal and optic nerve ischemia. So, what are the systemic features? ARN has been reported following and occurring simultaneous with HSV encephalitis and herpetic skin infection. Ocular feature presentation is initially with unilateral, with blurred vision and floaters. So, in this case, there is going to be the mild vitritis, like there are going to be the floaters. Pain is usually a feature. The anterior uveitis society criteria for diagnosis are as follow. So in this case, the vitritis are more common, and in porn it was minimal, whereas it is in this case it will going to be the much more vitritis. So the American Uveitis Society criteria for diagnosis are as follow: prominent anterior uveitis and vitritis, pan uveitis, episcleritis may occur, encefalitis may occur. So they're going to be very prominent anterior uveitis and vitritis. One or more discrete foci of the peripheral retinal necrosis, deep yellow-white infiltrate with the well-defined borders are seen. So in POD, first macula are affected, but in case of ARN, periphery retinal necrosis occur first. Retinal hemorrhages can occur but are generally less prominent than in CNV retinitis. The acute lesion resolve after 6 to 12 weeks. The acute lesion usually resolve after 6 to 12 leaving behind a necrotic retina with hyperpigmented borders. Secondary RRD is a major cause of a visual morbidity. So basically, in the case of ARN, there are going to be the white retinal necrosis that is going to be occur, and there going to be the retinal hemorrhage, and after that there going to be leaving after when the acute lesion resolve, which is after 6 to 12 weeks, they're going to be the necrotic retina with hyperpigmented borders. So let's see figure 12.54 is showing acute retinal necrosis. A is showing advanced disease reaching the posterior pole, and B is showing the full thickness retinal necrosis, and you can see the hyperpigmented borders in this. Circumferential spread of retinal involvement. Posterior pole involvement is late. Optic neuritis is sometimes a feature. Occlusive retinal vasculitis, including arthritis. Pre-retinal neovascularization can develop and may lead to vitreous hemorrhage, rapid progression of the disease in the absence of a treatment. So there going to be can occur vasculitis in a case of ARN. So what are the investigation? Vitreous and or aqueous PCR assay for viral DNA antibody assay is less effective. So treatment is basically antivirals. Acyclovir intravenously 15 milligram per kg every 8 hours for 10 to 14 days, and then orally 800 milligram 5 times daily for 6 to 12 weeks. This may hasten resolution of the acute retinal lesion and dramatically reduces the risk of secondary involvement. Long-term therapy is occasionally required. So first you will start the intravenous acyclovir, which dose is almost about 15 milligram per kg for 8 hours, and then which you give for 2 weeks, and after that you give 800 milligram oral 5 times daily for 6 to 12 weeks. Oral is well acyclovir and famciclovir may be substituted for oral acyclovir with similar outcome but better tolerability. Well acyclovir 2 gram orally 3 times daily can be used as an induction dose followed by maintenance dose of 1 gram orally 3 times daily. So basically you can also give val acyclovir which dose is 2 gram for 3 times daily, and after that you can give 1 gram 3 times daily. Intravitreal ganciclovir or foscarnet may improve the prognosis. Systemic steroid may be started 24 hours after the initiation of the antiviral therapy, especially in severe cases. Laser retinopexy around the necrotic area has been used in the past but has no effect on the retinal detachment rate and should be avoided. Vitrectomy for RRD commonly with the silicone oil tamponade. So herpes simplex interior uveitis. Interior uveitis may occur with or without active corneal disease. So herpes simplex can also cause the interior uveitis, and we are studying about all the cases of the viral uveitis. So HSV also causes interior uveitis, but sometimes without even corneal disease. Patchy and occasionally sectoral iris atrophy that includes the pigment epithelium is common, as is elevated IOP. The pupil may be larger than its fellow, as in Fuchs uveitis syndrome. KPs may be fine, stellate, and diffusely distributed across the cornea, but can also be large and grouped. So basically, in this case, uveitis can cause the patchy or the sectoral iris atrophy, and with they're going to be the raised IOP, and the pupil is larger than a fellow eye. There can be the type of anisocoria, and the KPs that will be formed on the cornea will be the diffuse and stellate and distributed all over the cornea like in the Fuchs uveitis. There is often a past history of herpes simplex keratitis, cold sores, and sometimes genital herpes. So you can identify because there is always going to be some kind of past history of herpes simplex. Recurrent episode of hepatic iritis involves the same eye in almost all the patients. Distinguish hepatic from the cytomegalovirus iridocyclitis can be difficult. So treatment is with the topical steroid, for example, or prednisolone acetate 1% 4 times daily, and a topical cycloplegics in a combination with uh, oral antiviral, for example acyclovir 400 milligram 5 times a daily. So in the case of uveitis that occur due to virus, if the cornea is not involved, then we give topical steroid to treat the uveitis.